All right. I think we will get started this morning. Welcome. This is Cancer Care Manitoba's A Healthy Tomorrow Starts with HPV Vaccination Today webinar. And we are very excited to have you join us. By way of introduction, if I could have the next slide, thanks. So I'm Donna Turner. I'm the Chief of Population Oncology, but also currently the interim president and CEO of Cancer Care Manitoba. And it's my pleasure to be the moderator for today's session. Before we get going, a couple of housekeeping things to make sure we're touching base with. First, please note that the session is being recorded so that we can make it available for viewing after today. And within about a week of this webinar, it will be added to Cancer Care Manitoba's website. So stay tuned and have a look at our website if you would like to review any of the material that you see presented here. Also, in the last 25 minutes of this webinar, we've set aside time to have questions from you, the audience. We've already received a number of questions prior to this webinar, but we'll cover those first. And then if there are questions that are coming from those that are on the line, we welcome you to ask them. And you're going to ask them using the Q&A box, which is at the bottom of your screen. So not the chat, but the Q&A box. And when you put in your question there, the panel will be able to see it, and we will go through those questions as best we can in the time that we have available. All right, so let us go to the next slide. As is required by doing webinars that are available for continuing education credits, all of us give a disclosure. So my disclosure that my relationship with our financial sponsors are none, but I do want to note that I have a number of grants or research support from the Cancer Care Manitoba Foundation, the Canadian Institutes of Health Research, Canadian Partnership Against Cancer, and I have an affiliation with the University of Manitoba, which has provided me with support for some of the work that I do there. I have no Speakers Bureau or honoraria to declare, no consulting fees, and nothing else to mention at this time. Now, I don't think any of these disclosures should bias any of the information that I'm presenting in this information or in this presentation, but just for your information. All right, importantly for us, we need to have a land acknowledgement. And so as we start this session today in a good way, this is Cancer Care Manitoba's land acknowledgement. Cancer Care Manitoba provides health services across Manitoba on the traditional lands of the Anishinaabe, Anishinaabe, Dakota, Eate, and Dene peoples. We acknowledge that Manitoba is also located on the homeland of the Red River Métis, and northern Manitoba includes lands that were and are ancestral lands of the Inuit. Cancer Care Manitoba acknowledges that colonial practices and policies have impacted the health and well-being of generations of First Nation, Métis, and Inuit who continue to experience inequities and obstacles in accessing healthcare, including cancer services along the cancer continuum. At Cancer Care Manitoba, we respect the spirit and intent of the treaties and treaty making and remain committed to working in partnership with First Nation, Métis, and Inuit peoples in the spirit of trust, reconciliation, and collaboration, while also improving cancer control and outcomes for all Manitobans. And really important for each of us to reflect on our own personal way on our journey in terms of acknowledging our role in harms of the past. And certainly I acknowledge that as the child of immigrants to Canada from Western Europe, that I have had many advantages that others have not, often perhaps to the disadvantage of our First Nations, Métis and Inuit peoples. And I certainly reflect on this as I work in my own way to reduce the impact of harms related to cancer in our community. So continuing to educate myself as I trust that we all are. All right. So the webinar objectives for today. So first of all, just to emphasize that we know the HPV vaccine is safe and effective in preventing cervical cancer, and the data continue to demonstrate its safety and effectiveness. During this webinar, we are aiming to meet the 4 objectives that are here on the slide. So first of all, identifying the eligible population and how to access the technology, that is how to get the vaccine. Secondly, explaining how the patient proceeds through the pathway. Thirdly, providing evidence-based information or evidence-based informed decision-making dialogue when you have those conversations with the patients. And finally, how to access more information in the future on this topic. So now we're going to move on to our very first presenter. It's my pleasure to introduce our gynecologic oncologist and medical lead of cervix check in Cancer Care Manitoba, Dr. Sarah Keane. She is going to start us off with a brief presentation about HPV and HPV-related cancers, as well as the importance of the vaccine in cancer prevention. Dr. Keane, over to you.
Thank you, Donna. Okay. So in terms of disclosures, I have no relationships with my financial sponsors. I do have a research support grant from Cancer Care Manitoba Foundation. No Speakers Bureau or honoraria, no consulting fees. I am technically an employee of Cancer Care Manitoba, sort of. I am currently enrolling patients in trials run by Merck, Novocure, Tesaro, CCTG, and Clovis, with follow-up in trials for Pfizer, AstraZeneca, and Merck. I don't stand to gain any personal benefit from these, but my patients may in accessing critical therapies. In terms of mitigating potential bias, I can't promise I'll say this, but I often, in the course of this conversation, discuss potential value of off-label use for non-availant HPV vaccination. And it often comes up in the Q&A of, can I vaccinate people outside of this cohort? And we can talk about the data and limitations there. And I'll let you know when we're doing that. Anytime I give this talk, I like to refer back to our land acknowledgement that Donna so graciously did for us, because I think that really centers the work that we're doing here in Manitoba. Among Indigenous people, cervical cancer is certainly prevalent. And I really like this quote because I think it really gets to the heart of the issue, that more than any other cancer, cervical cancer reflects striking global health inequity and access to healthcare even within our own province. And this talk today on vaccination is really critical for reducing some of those barriers and eliminating cervical cancer. Really, it's something that shouldn't exist at all. So. Next slide. So in 2020, the World Health Organization declared an elimination of cervical cancer. And they kind of formed this on 3 pillars that makes this disease completely preventable. And what we're going to focus on today is HPV vaccination. And so the target set out by the WHO was 90% of girls fully vaccinated with the HPV vaccine by age 15. So CPAC is the Canadian Partnership Against Cancer. And they kind of made similar pillars in line with Canadian healthcare systems and values. And so if you go to the next slide, we can see CPAC has made a priority to improve HPV immunization rates. And their target is a little bit higher than the WHO target, with 90% of 17-year-olds across the board, regardless of gender or gender identity, fully vaccinated with the HPV vaccine. The target was 90% by 2025. And so as this year unfortunately comes to a close, we are not at that target. And I think some of my other colleagues will speak to that a little bit later in the day. So this is a critical webinar in working on one of these very important pillars for elimination of cervical cancer. Next slide, please. It is particularly poignant because we have an uptick in cervical cancer, again, in a disease that could be completely eliminated and that we are doing work towards eliminating. And this isn't something we can blame completely on COVID. We started to see this prior to COVID. So in about 2018, cervical cancer rates started rising in Manitoba. This is not just Manitoba. We're seeing this across the country and even internationally. We're seeing an uptick in cervix cancer. Nobody really has a good sense of what is driving it, but it's there nonetheless. Unfortunately, Manitoba has the fastest rising rate of cervix cancer in the country. So we're doing this faster than anybody else. And we also have the highest number per capita in the province or in the country. So a lot of work to be done here. And again, vaccination is the most critical pillar here for the future. Next slide. I think most people are pretty familiar with HPV and its impact. We're talking a lot about cervical cancer because we have this goal for eliminating it, and it really is doable through a combination of screening as well as vaccination. But cervical cancer is not the only thing that's in play here. Certainly, I see a lot of vulvar cancer as a result of HPV, and oropharyngeal and anal cancers make up a huge chunk of this pie here. So vaccination stands to benefit a lot more than people with a cervix because all of these are going to be driven by HPV. And the prominent strains are still 16 and 18, so would be covered by vaccination. And the morbidity associated with these cancers is really quite significant. So lots of benefits across the board. Next slide. In terms of the vaccine, I just wanted to give a little bit of background information. There's several that are available. And in terms of questions that often comes up, you know, around approach to vaccination and how we do it. So I just thought this information was useful. So when this all evolved, there were two vaccinations that were available on the market. One was a bivalent HPV vaccination called Cervarix, and you can see that there incorporated HPV 16 and 18. And that really accounts for about 70% of all cervical cancers. Gardasil, or the quadrivalent HPV vaccination evolved right around the same time, and that included 6 and 11. And their marketing was kind of, well, if we get rid of genital warts as well, it's really going to sell people on it because for young people, it's hard to conceptualize, you know, getting cancer at some point in the future, but getting genital warts is certainly a health concern. And so the two were kind of at the market at the same time. The bivalent vaccine, they really tried to say, well, we have better immunogenicity, but with time, that didn't really pan out. Both vaccines have really, really excellent immunogenicity. And then the Gardasil vaccine evolved a little bit, and they added 5 more strains that have cancer-causing potential and made it a non-valent HPV vaccine. And this is currently what is available through the province. You can see that by adding 5 more strains, you don't really boost the coverage a huge amount because 16 and 18 drives so much of the disease associated with cervical cancer. But you do get a little bit more coverage there. So currently available, you can still get the Cervarix or the bivalent vaccine, and you can get you can get Gardasil 9, which is the non-valent vaccine. Gardasil 4 has been taken off the market. In terms of its composition, this is just a little picture of HPV. So it's a pretty simple little creature, but it has 2 proteins on its capsid. And so when you put the capsid protein, the L1, in a vaccine, it assembles itself in something that mimics HPV. And so this is essentially the composition of the vaccine that is the protein capsid. So it is not a live vaccine. It is safe to give in immunosuppressed individuals and even in pregnancy. So we do support that. You can go to the next slide. In terms of approaching patients, consent obviously is very important. It is a really nice vaccine in that it has minimal risk and side effect. The most common side effect in all of the trials from the bivalent to the non-valent vaccine was pain, swelling, and redness at the injection site. And people who have needle phobias, and particularly among adolescents, there is an increased risk of syncope, which would be standard for any vaccination consent. Anaphylaxis is, of course, a risk with any new medication, but it is quite low risk for this. And the immunogenicity that you get associated with this vaccine, like I said, it's a very, very good vaccine that is more robust by far than even the natural immunity associated with HPV infection. There's lots of data that HPV is cleared by cell-mediated immunity, and so the immune response that you get is not as good as that you would get with vaccination. So people can get reinfected with the same strain of HPV over and over again, which could be halted by HPV vaccination. So there's very few contraindications to going ahead with HPV vaccination. Next slide. I like to put this up, and we're going to reiterate it a few times today. Manitoba has one of the few provinces that has a once eligible, always eligible policy in terms of approach to vaccination. So that means that if you qualified for it in the school years when you were in grade 6 and you didn't get it for whatever reason, and I could give an entire webinar on reasons why people don't get vaccinated and how to approach that, then you are always eligible. So if you missed it in school and you come back as an 18-year-old to your family doctor and say, hey, I really want this, this is important, then it should still be free and covered by the province. And then we have this other cohort of criteria which can be applied for higher risk individuals. For myself, I do a lot of HPV vaccination for the females 9 to 45 years who have a newly diagnosed high-grade cervical histopathology result. So in my colposcopy clinic, everybody who gets treatment for high-grade cervical dysplasia or precancer leaves with an HPV vaccination, or at least an offer of. And we have it set up now so that the nurses can vaccinate in clinic. I think Dr. Singh will talk about how to access that, but we have the vaccine warehouse stock and we do it right in our clinic so patients don't have to navigate accessing vaccine in the community. And it's made a huge difference in terms of uptake, even in my little clinic alone. Okay, next slide. I think that's my last slide. Yeah, there we go.
It is. Thank you very much, Dr. Keene. So that's an excellent background in terms of about HPV and why we're talking about vaccination today. And so moving to our next speaker, Dr. Devinder Singh, who's a medical health officer of health for Southern Health Santé Sud, and he's going to walk us through vaccination rates in Manitoba, eligibility criteria, and being ready for vaccination requests. Over to you, Devinder.
Great, thank you, Dr. Turner. And as stated earlier, we're all going through our disclosure slides, so I don't have any relationships with financial sponsors or grants or Speakers Bureau honoraria or consulting fees, but I'm an employee of the Government of Manitoba. I'm the Manitoba representative for the Canadian Immunization Committee, which is a federal, provincial, territorial committee that discusses immunization issues and tries to, coordinate responses across the country related to immunization. I'm the CIC, so Canadian Immunization Committee liaison to the National Advisory Committee on Immunization, NACI. So I'm a non-voting member on NACI, and I have a nil salaried appointment, so not a paid appointment, to the University of Manitoba in what was formerly the Department of Community Health Sciences, and now now its own college. So next slide, please. I don't believe any of these disclosures would bias the information I'm providing here, but providing just the comprehensive information for your benefit. Next slide. So HPV vaccination rates, as mentioned previously, the target for the overall cervical elimination plan is to get to 90%. As you can see, we're not at that target yet. However, fortunately, we are trending in a positive direction for both males and females overall, with some variability across years with females. So still room for improvement, but taking the positive that we are trending in a positive direction. Next slide, please. In terms of the schedule that we use in Manitoba, so we have not changed our schedule. Still use the 2-dose schedule for healthy individuals, so not immunocompromised, who are 9 to 14 years of age, or if someone starts the schedule between 9 and 14 years of age, then they would remain on this 2-dose schedule, provided 6 months apart. However, if you start the schedule an older age, so 15 years of age or older, then you'd be on the 3-dose schedule, so 0, 2, and 6 months. Or if you're immunocompromised or have HIV, regardless of whether you're immunocompromised with HIV or not. Next slide, please. So as Dr. Keene had mentioned, we're fortunate in Manitoba to have a once eligible, always eligible approach to immunizations for almost every immunization that we offer. And it includes HPV. So regardless of anyone's, medical history, if you have a female patient who's coming to you who was born on or after January 1st, 1997, they are eligible for HPV immunization. You don't have to look for any other reason to see if they're eligible. All females born on or after January 1st, 1997 are eligible, and all males born on or after January 1st, 2002 are eligible to receive HPV vaccine, and this has to do with when the program was started for those cohorts in school, all the time ago, when this program started. So that's the reason for the difference in the two sexes there. Next slide. However, as mentioned earlier, if someone doesn't qualify under those eligibility criteria, they may still qualify under these extended high risk eligibility criteria, and some of the more common reasons might be, as Dr. Keene had mentioned, someone with a newly diagnosed high grade cervical histopathology result, or someone who's immunocompromised, and depending on their sex, males between 9 and 26 or females 9 to 45. Those are just examples of reasons why people may also be eligible despite not being in the birth cohorts that I had mentioned previously. Next slide. So the most important factors that relate to uptake of immunization from the literature are a recommendation from a trusted healthcare provider and a convenient way to access immunization. So this is critical. This is where all of you come in. You are the trusted healthcare providers for your patients. And as Dr. Keene mentioned, hopefully a convenient way to access the immunization. So, even just having the barrier of, oh, I don't offer it, but if you go across the street, you can get the vaccine, that you will have patients who will not go to get immunized, who would have been immunized in your office if you had provided the vaccine there. We know that just from like years and years in the real world and in the literature, that is a barrier, and you will lose some patients in terms of vaccination. So it's critical that you offer immunization in your practice, if at all possible. Next slide, please. So the order form, I think this will be repeated as well later, but the easiest way to find the order form, if you're not already familiar with it, is to just Google Manitoba Health Vaccine Order Form. That's how I always find it. And it highlighted there is the HPV order. The minimum order is just a single box, which has 10 doses. So, it's not a large order. It wouldn't take much room in your fridge. And, hopefully you can add this to your practice if it's not already part of your practice. Next slide. And we have basically all the information you would ever want to know about the immunization program on our website. So there's the link there if you're not already familiar with it, but you could also Google, immunization program Manitoba to find it, and we have everything hopefully that you would need there. And just to mention last thing, so for any of the vaccines that we offer in the publicly funded immunization program, you do not need a prescription for them. So anyone coming to you saying that they're eligible for immunization, you don't need a prescription, and you don't need proof of their eligibility. If you're unsure if they're eligible, you can ask them, what criteria they would fall under, and you might provide them the criteria. But if they say, oh, I have X, Y, or Z, then that's it. That's all you need. You don't need a prescription. Just make sure that you try to only use the publicly funded vaccines for people that are eligible. That's critical. But if they say that they're eligible, that's it. You don't need a prescription. So just want to leave with that. Thank you.
Thank you very much, Dr. Singh. All right, so some really great basic information now, as well as about the vaccine itself. So now we are really pleased to have Britt Corral joining us today. Britt is a pharmacy practice advisor with Pharmacists Manitoba, and she's worked as a pharmacist manager, a pharmacy owner, and an experiential education facilitator with the College of Pharmacy. And she's going to walk us through talking to patients about vaccines and the next steps to administer the HPV vaccine and a few other factors that you may need to consider. Britt, over to you.
Thank you, Dr. Turner. So my disclosures are fairly straightforward. There's not much here. I don't have any relationships with any financial sponsors, any grants, Speakers Bureau, consulting fees. My only disclosure is that I have worked with Emergent as a trainer for their naloxone products. Next slide. and my disclosures are not anticipated to bias the information that I'm going to provide in this presentation. Next slide. Next slide. Thank you. So over the next 7 minutes or so, I'd like to highlight how pharmacists can play a role in increasing vaccination rates for HPV. And I'm going to go over some of the logistics of vaccinating and identify some resources. We'll talk a little bit about how to raise awareness of the benefit of HPV vaccines, talking about how to identify who's eligible and what to do if they're not. We'll touch a little bit about FIMS and the importance of keeping it up to date as well. But a stat that I've learned recently preparing for this webinar is that pharmacists are responsible for less than 1% of all HPV vaccinations in the province. And while this stat reflects that physicians, nurses, and other healthcare practitioners are really playing a large role in this space, it does highlight that there's an opportunity for pharmacists to play a larger role in promoting and delivering HPV vaccines in this province. So next slide. So we saw this order form earlier. I think it's really important that everybody understands how simple it is to order HPV vaccine in their pharmacies and have it available. It is very easy, as Dr. Singh mentioned, to find it. It's a quick Google form. There's also a link that I'll show you in the next resource, but you just fax it or email the order form into the provincial warehouse. Because it's a publicly funded vaccine, there is no cost for the vaccine or the shipping to your pharmacy. And it's really important to always keep a supply of the publicly funded vaccine on hand so that you don't miss out on the opportunity to vaccinate a patient while they're in the pharmacy and ready to receive it. Next slide. So this is a link that will appear in the chat. I'd recommend that you pin it to your desktop. It has great resources and materials that you may want to utilize, including the order form that we just looked at. It has all of the schedules for the HPV vaccine as well as other publicly funded vaccines. You'll find consent forms, fact sheets, even access to the FIMS training that's required. You'll find information about adverse events reporting and a competency guide for those administering vaccines, among many other resources. Next slide. So I'd like to spend a little bit of time just talking about how to raise awareness of the benefit of HPV vaccines and ways that we can increase uptake. And of course, this is from the pharmacist perspective, but it's applicable with other situations, of course, as well. Being prepared to have conversations about vaccines is really important when we're working to increase vaccination rates. And that's when we talk about HPV vaccines, there are many different ways we can approach these conversations. So there's a few different things that I'd like to just touch on quickly to talk about those points. So having some easy to discuss statistics and information to prepare yourself for these conversations can be really helpful. And as healthcare practitioners, we talk a lot about, HPV vaccines. We use jargon and lingo that sometimes our patients and the general public maybe doesn't understand. And keeping things really simple and just saying something as straightforward as HPV is a group of viruses that can cause diseases like genital cancers and warts. Keep it simple. Open conversations. It's very easy to just start a conversation with something general like that. Another stat that is good to have on the ready to have conversations is thinking about using the stat that more than 80% of people who have sexual contact will have at least one HPV infection in their lifetime. That's very impactful and can really help to continue conversations or start a conversation with people that you want to encourage HPV vaccinations with. As Dr. Singh had mentioned, we also know that patients are much more likely to be vaccinated when it's been recommended by a trusted healthcare practitioner. And simply changing the phrasing that you use about vaccines can really make a difference too. So using presumptive recommendations and saying something like, it looks like your child missed their dose last year, why don't we get them caught up today? Instead of saying, would you like to have your child vaccinated today, can really increase the uptake of vaccines. We also talked about how being accessible is really important in providing vaccine services. And pharmacists are considered to be one of one of the most accessible healthcare practitioners, which puts us in an ideal place to do more to increase HPV vaccine rates. So whether you book vaccine appointments in advance, maybe you accept walk-ins, or maybe you simply work to keep some time protected in your day to allow for vaccine services, ensuring that the staff that you work with and the community that you serve understands how to access these services is really important. And then, of course, always making sure that your workspace is ready to utilize to provide these services is very important. Making strong recommendations and being able to reduce and address objections is also really important when you're trying to increase vaccination rates. And you can use motivational interviewing techniques such as OARS, which is using open-ended questions, affirmations, reflections, and summaries to try to move the needle forward, and being able to have conversations, reduce objections, try to get to a place where people are more acceptable and willing to receive vaccines that you think are important and you're recommending. And then also using the ask, provide, verify method to be able to, again, start conversations, keep those conversations going, and be able to ultimately help improve the vaccination rates overall. So these are just a few strategies you can employ to engage patients and caregivers. Next slide. So we talked a little bit about eligibility, and we've discussed how you can find the vaccine eligibility. You may be having conversations about HPV vaccines with parents or guardians of children who missed one or both doses, or adults who may or may not know if they're eligible for HPV vaccines. So pharmacists can administer the publicly funded 9-valent HPV vaccine starting at the earliest age that is indicated, which is 9 years old. And in Manitoba, it's part of the school-based immunization program given in grade 6 in a 2-dose schedule, so usually around the 11 years old mark. If a child has missed one or both of their doses at school or is maybe homeschooled, pharmacists can catch these children up with either a 2-dose or 3-dose series based on their age. And when adults present asking about HPV, it's really important that we invite those conversations and respond in an inviting way and say, you know what, glad you want to have some more conversations or learn more about the HPV vaccine, and then go on to gather the information that you need to determine if they fall into the once eligible, always eligible category, or maybe they fall into one of the other eligibility categories. But when you're thinking about these conversations, and a pharmacist identifies a patient who might benefit from HPV vaccines, we're going to consider things like, is the vaccine indicated, of course, is the patient fully vaccinated, consider timing with other vaccines that you might be giving in that appointment or in the near future. And then we're really going to think about the eligibility. And as Dr. Singh said, we want to make sure we capture as many clients as possible with the publicly funded vaccine, review the criteria, understand the criteria, and consider carefully where that patient fits in. And if they don't fit into those criteria, then you can still help that patient receive a vaccine by requesting a prescription from their primary care provider or have them make an appointment to be seen. And last slide. So last but not least, just a word about FIMS. We know that flu and COVID vaccines must be entered directly into FIMS within 2 business days of it being administered. Whether it's publicly funded or not, all vaccines, including HPV vaccines, which are administered by pharmacists, have to be recorded into FIMS ultimately. And the way that this translation of information into FIMS occurs in the pharmacy setting, with the exception of flu and COVID, is using the P's and Peter, S's and Snow adjudication code to be entered in the adjudication screen of the pharmacy software prior to sending the claim to PharmaCare. Of course, making sure that FIMS receives this information is important for many reasons, but we want to make sure that clients' medical records are kept accurate. It helps to support effective disease management and decisions around treatments, and it ensures accurate predictions of future potential doses of vaccines. So I'll pass things back to Dr. Turner.
Thank you very much, Britt. All right, so so now that was nice adding in the pharmacist perspective and how this works on your end. So now I'm very pleased to introduce Shauna Fay. Shauna is a health educator with Cancer Care Manitoba's screening and prevention programs, and she's going to highlight the new resources that are available to you to assist in promoting HPV vaccination and providing accessible information for the Manitobans that you serve. Shauna.
Hi, yeah, my name is Shauna Fay. I am an employee of Cancer Care Manitoba. I'm a health educator here. I have no other disclosures, and it is not anticipated to bias the information that I'm presenting today. So I do just want to detail some places where you can find supportive resources for patients and family. So Cancer Care Manitoba and the province of Manitoba have collaborated to update and translate the grade 6 school immunization program fact sheet. And so that fact sheet goes through HPV, Hep B, and meningococcal vaccines. So this resource is now available in 15 languages on the provincial website. So if you are working with communities or families who can benefit from this information, please use that and spread the word. I'm going to put that in the chat. Oh, thank you. It's already in the chat. We've also created a new plain language short video for parents and caregivers highlighting the vaccines in that grade 6 school immunization program that prevent cancer later in life. So this video was informed by feedback we had from the Provincial Immunization Coordinators Practice Council, as well as school immunization nurses, and published resource on vaccine decisions. So if you logged onto this webinar early, you probably saw this playing on loop in the waiting room. If not, it's available through our prevention page, which is www.cancercare.mb.ca/vaccines. And it will very soon be available with subtitles in 7 Indigenous languages. So if this is useful to you and your communities, please feel free to access that. And then last but not least, for clinical and pharmacy spaces, we've created a new poster to spark conversations around HPV and Hep B vaccines with folks who may be unsure of their status or may have missed in grade 6. So this is available for download or order from Cancer Care Manitoba's website. It's in the screening resources under the prevention tab, but we have put this link into the chat for you, so you can go ahead and access those right now if you like. Thank you.
Thank you very much, Shauna. All right, so there's lots more information that you can find again through Cancer Care Manitoba's website if you go and have a look. Also, note the Government of Manitoba Public Health site is also being shared with you in the chat. So those are some really good resources. We're going to use the rest of the hour to answer some questions that we've been aware of that have come up to us over time, but also ones that people shared with us when they registered for this webinar. And so just a reminder that if you do have questions, please do put them in the Q&A box at the bottom of your screen, and we will work through those as well as the ones that we have that we had previously from when people signed up. All the presenters here are available to answer your questions, and we also want to acknowledge that we all have an additional voice at the table, a colleague in primary care. And so just to introduce you, Dr. Tunji Fatoy, who is a family physician in oncology at Cancer Care Manitoba and an academic family physician with the Department of Family Medicine at the University of Manitoba. Dr. Fatoy, I'll let you do your disclosure and mitigation slides, and then we will go to our first question, which is going to be for you.
Thanks, Donna. So as Donna said, I'm Tunji Fatoy. I work for Cancer Care Manitoba. My one disclosure is I did receive honoraria for speaking at the CAMPAT conference, which is the Canadian Association of Nigerian Physicians and Dentists. But if we go on to the next slide, I do not expect that any of that will bias the information I'm going to be providing in this presentation.
All right, thanks very much, Dr. Fatoy. So let's go to our first question. And so this one, as I warned Dr. Fatoy, is going to be for him. So he's all keyed up and ready to go. So the question is, my patient is not eligible through the Manitoba immunization program, and the cost of the series is too much for my patient. What's your response for that?
Yeah, so, some of those answers are already kind of being talked about. So one of the things we can do as primary care providers, if we have a patient who has a private health plan, or they work for government or they work for an organization and they have Blue Cross or Canada Life, we explore that and see if they do have that and they're able to cover that. The other option is, can we consider a less expensive option to the 9-valent vaccine? And as Dr. King said at the beginning of our presentation, the 2-valent vaccine, the Cervarix, is still available in Canada. It is less expensive than Gardasil 9 and would still provide protection against the two most common variants of the HPV that cause cervical cancer, the 6918. It's not the best, but it's some protections better than others. And if there's anything that I could add to that for a patient, the cost of the series is too much for the patient. Can the patient afford one dose? And Dr. King had mentioned it. While that's not sort of standard of care, there's been quite a lot of talk and ongoing research into the efficacy of a single dose of the Gardasil 9. And Sarah, if you want to jump in a little bit there with some of that evidence, I'll be happy for you to.
For sure. And I think it addresses one of the questions in the Q&A, which I am going to ultimately turn over to Dr. Singh. But there's some evidence that's coming out around single dose or 2-dose series. So the single dose would be ideally aimed at the under 17 cohort and 2 doses for the over 17 cohort. And the data is showing that there's really good immunogenicity, so lab values. We don't have longer term data to correlate that to cancer risk reduction necessarily, but some provinces are already shifting to a 1-dose series. So I think that any HPV vaccination is better than none. So if cost is a barrier and you have a patient that's at risk, then I would say let's start with 1. There's also good evidence that we don't need any boosters because the immunogenicity is very good. And if you interrupt the series, then you don't have to start again at the beginning. So even if they got 1 now and 2 years later they could afford the second one, then I think there's still enough evidence that there is benefit, even though that technically would be off-label use or not the appropriate dosing series. But I think the patient still stands to benefit from it.
Thanks, Sarah, for adding to that.
All right. Yes, thank you both for that answer. All right. So it's good. We're seeing that there are some other questions coming into the chat. I'm going to go to the next question that was sent in advance. If we could go to that next slide. If my patient has never been sexually active, does it make sense to have them still get vaccinated against HPV? So, Dr. Fatoy, your thoughts on that?
Yes. So, in medicine, we always say prevention's better than cure, right? So this is one very good example of that. I would still recommend them to get the HPV vaccine. This is one of the reasons why they target them in school age, I believe, in grade 6. But regardless, if you have a 18, 19, 20-year-old who's eligible and has never been sexually active, I would still recommend that they get the HPV vaccination, because the purpose of the vaccine is to prevent HPV infections, not to treat HPV infections. So even though it can still provide some of that benefit, so yes, it is. It's the best way to maximize the benefit of the vaccine. Dr. Singh, you have your hand up.
Yeah, I would even go stronger than that. I'd say this is exactly the person that you want to vaccinate. is before they're sexually active, which is, as you said, Dr. Fatoya, is the reason why we immunize so early. We want to immunize people before they're sexually active. So this is actually the ideal person to immunize is before they're sexually active because they haven't been exposed to HPV, and then you have the full benefit of prevention. So this is the most important like group to immunize is before they're sexually active. Still benefits after, but this is the ideal time is before they're sexually active.
Thank you for that. So I'm actually just going to go a little out of sequence for the panelists as a heads up. We've got a number of questions that are in the Q&A, and I'd like to just see if we can address some of those. I wonder actually, Dr. Singh, this might be for you. This question is, why does Manitoba Health not adopt the Public Health Agency of Canada guidelines for HPV vaccination?
Great, thank you, Dr. Turner. Thanks for the question. So I think this is alluding to what Dr. Keene had mentioned, which is that some provinces and territories have gone to the NACI recommendations, which is a single dose for those aged 9 to 20, and then 2 doses for those aged 21 plus. And the reason for that for Manitoba is that there's some very potentially impactful randomized control trials that are nearing completion that we believe are likely to provide evidence in some critical areas that currently don't have the evidence. So there seems to be some very strong evidence for this NACI schedule for cervical cancer prevention. But we don't have evidence in the other critical areas like prevention of anal cancer, anal infections, prevention of oropharyngeal infections, and importantly, the randomized control trials that are currently underway, one of which should have just been completed now, and then the other should be completed in 2026, about May, and then we'd expect results maybe 6 months after that. Those should inform these other critical outcomes. And we just want to be sure that if we switch the schedule, we're still covering, these other essentially 2/3 of cancers that are non-cervical that can be prevented by preventing HPV infections. So it's just we want to have that evidence before we make the switch, because we don't want to switch back if we do change. Just for lots of reasons, including patient confidence in our program.
Yeah, thanks very much, Dr. Singh. So really, the evidence is continuing to come in, and I think, it's really important that we remain science-based and evidence informed as we move forward in this space. There's another question in the chat about how long have pharmacists had access to the public supply of HPV vaccine in Manitoba? So Britt, I don't know if this is for you or for Dr. Singh, but I will throw it open to anyone at the table. Dr. Singh has his hand up, so fire away.
Well, the regulation allowing pharmacists to immunize for HPV came into effect in 2016. So I would imagine since 2016.
All right, good to know. Thanks very much. So I'm going to take the third question, then we're going to sort of switch back for a couple more questions of previous ones that we had. But the questions, first of all, thanks from one of our participants for the great presentation, and wondered about what the recommendation is for approaching families that don't vaccinate at all. And there's a significant number in the Southern Health Santé Sud area where this person works. I think, Dr. Singh, I'm going to start with you, because I think you, as the medical health officer in that area, have likely had some experience in this regard.
Well, I think the key is that what was mentioned earlier around the motivational interviewing kind of approach is to be open and curious about what the patient, what the family is thinking, and to in a non-judgmental way try to just answer any questions that they may have, because they may one of the more common things is, well, my child isn't sexually active. I want to wait. I don't see a benefit. You're talking about preventing a sexually transmitted infection. I don't see a benefit, because they're not sexually active. And so that's where, you might say that, this is exactly the time where it's best to immunize, to get into the specific reasons that they may be wondering about or that they have questions about, recognizing that, you're not going to, not everyone's going to choose to immunize. And they may not choose to immunize now, but maybe they will the next time you talk to them, or maybe they will the time after that. And so, just, and to be supportive that this isn't the only thing that you're there to help them with. Like, you're their healthcare provider for a whole host of things. And even if they choose not to immunize now and take this recommendation, maybe you can help them with something else, and maybe they'll trust your judgment about this later once they realize that you're there for them and you're just trying to serve them as best as you can. So that would be the approach that I would take, and hopefully you'll at least be able to have some families choose to immunize that may not have otherwise.
All right, thank you very much. I'm going to take one more question from the chat. I'm going to direct it, I think, to Dr. Keene, and that is, if a patient has the older HPV vaccination, the 4-valent, would it still be beneficial to still immunize with the non-valent or the 9-valent version?
That is a tricky question that doesn't have really good evidence to support. But what I typically say to people is kind of look at risk and look at eligibility. Most of the people who are old enough to have gotten the quadrivalent won't fall under the age-related cohort vaccine, so they wouldn't qualify for it free there. But if they do meet one of the other higher risk criteria and it is still covered by the province, I think it's reasonable to consider. And then you also have to look at risk factors for ongoing HPV. Again, most of the patients that would have accessed quadrivalent vaccine would probably be, I'm just trying to think of timelines and stuff. I would say they're probably going to be in their late 30s and early 40s, right? And so if you have somebody who got quadrivalent and is now in a monogamous relationship with no intentions of encountering new HPVs, then I think telling them, well, you have to pay for this out of pocket is not necessarily indicated. But if you have somebody who is maybe still single with several partners and encountering different strains of HPV, then it may be reasonable to recommend. So if you look at the individual risk profile for the patient, including financial risks for them, then I think you can make a decision. It's reasonable to consider in higher risk people, but again, the benefit going from Gardasil 4 to Gardasil 9 is only about an extra 10 to 15% in terms of coverage and cancer risk reduction. The vast majority of cancers are still going to be driven by 16 and 18.
Great, thank you. That is, yeah, that's a complex
It is.
scenario. Yeah. All right. Well, we're going to go back just to another question that we had previously, but then we'll hop right back into our the questions that are coming in on the Q&A. So the next question that we have is for Dr. Singh again. So I don't know if Shauna or Leslie could advance the slide. What if the pharmacist is unsure about giving an HPV vaccine to a patient and their eligibility to have it covered by Manitoba Health? So Dr. Singh, comment on that?
Great, thanks for the question. So I think important dates to keep in mind: any female born after January 1st, 1997, any male born after January 1st, 2002, you don't need to go in any other eligibility, they're eligible. So, keep those dates in mind for HPV vaccine. But if, they don't fall under that, and then you're looking at the extended eligibility and you're unsure, just ask the patient, and you can provide the eligibility to them and just ask them if they would fall under any of those criteria. That they may need some help in terms of understanding the language if it's something around being immunocompromised, but chances are they know, and you don't need a prescription and you don't need proof. If they identify that they're eligible under the eligibility criteria, that's all you need, and then you just immunize.
All right, thank you. And I like that there's the QR code is up on the screen for folks who want to have that information close at hand. Going back to the Q&A, and I think this will be a question for you, Dr. Keene, although of course anybody can hop in. Why do we not offer Gardasil to partners of cancers caused by HPV? The querier says, I've got a client whose partner now has throat cancer caused by an HPV strain, but the wife is not eligible. Is it not beneficial?
That's an excellent question. It is beneficial, and I think that it probably should be offered. And again, qualify is a relative term, right? She may not qualify for a provincially funded vaccine, but it still is a reasonable thing to offer vaccination if she has alternative means like private coverage. There's even some data that, again, when you speak to the immunogenicity of the vaccine, that in a monogamous couple, that vaccination can halt that kind of flipping back and forth of a strain and reinfection. So I do think that this individual might stand to benefit, but you also have to look at other things like, is she 65 or 70 years old? Is she 40 years old? What kind of, like, she's almost certainly already been exposed to this vaccine or to this HPV strain. So it's again a very complex question with no absolute answer for her, but taken at face value with the information you provide, it's not unreasonable to vaccinate her. It just may not be covered by the province.
All right, thank you. So the next question we have in the Q&A is that the person says, I've had patients decline HPV vaccine for religious reasons, which seems to be related to having a single partner throughout both partners' lifetime. Are there techniques for motivational interviewing for this population? I'll throw it, it's an open question for any of our presenters.
I can speak to that if you want. I mean, basically what I say to patients in this situation is nobody can predict the future, right? And perhaps you do intend to be monogamous, but sometimes partners die and people remarry, and that may also be somebody who's had another sexual exposure. The other thing that you can't necessarily account for is non-consensual exposure. So assault would still transmit HPV, and you just never know what's going to happen to somebody. I mean, not that it's a good thing to say to people necessarily, but there's some evidence that non-paternity in pregnancies is as high as 10%. And so just because somebody says that they have never had another partner doesn't mean that they in fact have never had and never will have another partner. So, I mean, obviously, you know your patients and their religious inclinations better than I would, but I think speaking to the unpredictability of the future is probably the best way to approach that.
All right, thank you. There was another question actually that I just wanted to sort of works in. At what point does a PAP screen become irrelevant, or does it never become irrelevant?
It's never irrelevant. I'm glad you got to that one. It's very important. Even in fully vaccinated individuals, PAPs are critical. At some point, we'll be moving to HPV testing, I hope, and it still will be relevant.
All right, thank you for that. We've got the references on the slide. I'm going to try to squeeze in these last two more questions. Why doesn't Manitoba Health cover HPV vaccines for those born before 2002 or 1997 for males and females respectively, who may be at highest risk? So those that are sexually active, not vaccinated, and low income. Dr. Singh, any comments on that?
Well, we're continually reevaluating the eligibility criteria. And so the reason for the dates for, going on or after January 1st, 1997, 2002, that has to do with the once eligible, always eligible policy. That when we start a program, the cohort that's eligible for that program continues on, even if they missed it. So that's a critical part for catching up people that miss immunizations in Manitoba. And then as for the evaluation of the other high risk criteria, that again is being continually reevaluated, and those were the highest risk factors at the time that it was last decided upon, but it doesn't mean that those will be the highest risk factors in the future. So, in the future, those criteria could change. So it's important to keep up to date and check the website about the eligibility criteria in case there's any changes, which we also send out in memos to healthcare providers.
All right, thank you very much. So the very last question, hoping everyone can forgive me the extra minute. The last question we have in the Q&A, I've seen on social media that some people claiming that decline in HPV cancer rates is due to improved screening. Is there real world data that supports the efficacy of vaccination while adjusting for improved screening as a potential confounder? So Dr. Keene, you're the medical lead for cervix check. How about you take that one?
I mean, absolutely. Screening reduces the incidence of cervix cancer. This, cervical cancer screening is the poster child for screening. You can intervene before it's invasive disease, and it is an easy test to do, but not everybody does it. And so, a lot of the data does look at both pillars as critical for eliminating cervical cancer because there's going to be gaps, right? HPV vaccination is not perfect. It doesn't cover every single strain. Screening is still indicated as a result, but the flip side is true, is not everybody can access screening in an appropriate fashion, and screening is not a perfect test either. I mean, sensitivity for Pap tests is like 58% or something like that. It's really quite poor. HPV testing does marginally better, but it's still not 100%. HPV testing, I think, is going to perform better in an era of highly vaccinated individuals, but it's still going to be critical for both things to completely eliminate cervix cancer because both are going to have gaps.
Yeah, and I think that's the reason for both the recommendations of regular cervical screening still every few years is that it gives us the opportunity to really boost those the performance status and catch things.
And use your screening as an opportunity to discuss vaccination for individuals.
Yes, exactly. All right, so thank you everyone for joining today. We hope we've provided you with some powerful information about the role of HPV vaccination in preventing the cancers of the cervix, vulva, vagina, anus, oropharynx, and penis. And we really note that by counseling patients and supporting vaccination, you are helping to protect the future generations and reduce the burden of these cancers. So thank you very much for your participation. And if you have any questions that come up afterwards, please email us at the screening email shown here, screening@cancercare.mb.ca. And we will be looking at those. You'll be receiving a short evaluation form tomorrow. So watch your inbox for that. And also you'll receive a Zoom link to the email with an email link to generate your own certificate of participation. So if you need this for your continuing education, please follow that link that you get from us via Zoom, and that's how you will get your certificate. And on behalf of all of us here on the screen and Cancer Care Manitoba and our various partners across the healthcare system, thank you very much for being here, and we look forward to seeing you at a future session.